Hi, welcome to our channel. In this podcast, we're going to talk about the rheumatoid arthritis in the field of rheumatology. We have this privilege, and we are very honored to have Dr. Radin. He's going to talk about the medical aspect of rheumatoid arthritis. Dr. Radin, the stage is yours.
Thank you so much, Dr. Shayan, for the introductory part of the video. Today, I'm going to talk about rheumatoid arthritis, about the definition, etiology, clinical features, diagnosis, and finally, the most important part, the treatment. And so rheumatoid arthritis is a chronic, systemic, and inflammatory autoimmune disease, which is primarily affects the joints, and it will lead to pain, swelling, synovial destruction, and also deformities. It has different types of etiology. It might be idiopathic, also it might be genetic, which HLA DR4 and DR1 have really important effect on it. Also environmental factors like smoking, and also hormonal factors like female sex hormones increase the probability of the RA. As you know, female tend to have RA more often than male. So the female sex hormones have really important effect and factor in the developing of this disease. And also those who have a family history of the RA tend to have the disease more often than those who don't have the family history. The most important part of the topic, which is the signs and symptoms of RA, is the polyarthralgia, the clinical symptoms. Polyarthralgia, which is the symmetric pain and swelling of the joints, which is more affecting the metacarpophalangeal joints, proximal interphalangeal joints, wrist joints, and knee joints. And rarely it might affect some distal interphalangeal joints as well. In the human body. And these patients have morning stiffness, which is more than 30 minutes, but it is improving with the activity. And the joint deformities such as swan neck, boutonniere, hitchhiker, ulnar deviation of fingers, piano key sign, hammer toe or claw toe, and flat foot. As you can see here, like swan neck in the middle picture. The swan neck is so the proximal interphalangeal joint is hyperextended and the distal interphalangeal joint is flexed.
So, doctor, the difference between swan neck and boutonniere is actually the PIP. So, in the swan neck, the PIP is hyperextended, but in boutonniere is flexed. It has an appearance of a swan, like in the swan neck.
Exactly. So these two are opposite of each other. So the boutonniere is the PIP flexion, but in swan neck we have PIP hyperextension, and it's vice versa for the BIP. So BIP flexion in swan neck and BIP hyperextension in boutonniere deformity. And hitchhiker, which is a Z deformity of the thumb, which is the hyperextension of interphalangeal joints with the flexion of the middle metacarpophalangeal joints. And other important symptoms, which we call them extra-articular symptoms, as you know, Dr. Shayan, such as fever, myalgia, muscle pain, malaise, fatigue, weight loss, pleuritis, rheumatoid nodules on the skin, anemia, splenomegaly, which is the enlargement of the spleen, neutropenia, the decrease in the neutrophils, carpal tunnel syndrome, pericarditis, also, which is the inflammation of the pericardium, increased risk of MI and stroke. These are the extra-articular symptoms, which means that those symptoms which is outside the joints. So you have to divide them into two categories: articular symptoms and extra-articular symptoms. And but the most important clinical symptoms are the polyarthralgia and morning stiffness. So extra-articular are less common, but we see in these patients also. About the subtypes, I don't want to go into details, Dr. Shayan, because these subtypes are not that important, but I would like to talk about the rheumatoid arthritis of cervical spine and Feld syndrome more in depth, but the other types are not that common, so I don't want to explain too much about those types. The rheumatoid arthritis of the cervical spine is actually really life-threatening complication, which is caused by the inflammatory destruction of the ligaments, which is affecting the atlantoaxial joint and also the intervertebral joint. And patients with this type of the RA usually complain with the pain and also stiffness of the neck, which is typically early in the morning, but it goes away after rest. So they have the pain, but these symptoms sometimes goes away with the rest, but sometimes it won't go away. So that's really important clinical feature of this type. And also neurological deficits such as cervical radiculopathy and peripheral paresthesia, which is the pins and needles in the patients. And the only treatment for this type is the surgery, which they have to perform surgery to get rid of the pain. About the Feld syndrome, which is a severe subtype of RA, and it has a clinical triad, which is consisting of 3 different features, such as arthritis, inflammation of the joints, splenomegaly, which is the enlargement of the spleen, and neutropenia, which is the decreased amount of neutrophils. And there are other different symptoms which are also important, which I'm not going to talk about it in this video. But the most important part of the RA, which is diagnosis and treatment, about the diagnosis, we can say that we can do the clinical diagnosis. As you know, Dr. Shayan, painful joints and joint stiffness are really important features in RA. And also synovitis, inflammation of synovial capsule for more than at least 6 weeks. So these patients come to our office and complain of joint pain and morning stiffness. And what we do is do the laboratory tests, routine laboratory tests, such as inflammatory markers. We check the CRP level, ESR, CF, CBC, thyroid function test, and also some specific parameters such as ACPA, which is really important. Also, the anti-citrulinated peptide antibodies, which is elevated, and also RF, rheumatoid factor, and anti-CCP, which is also important. And about the imaging, X-ray and MRI would help us in the diagnosis of the disease. For the treatment, we have 2 different types, acute and long-term. So for the acute treatment, we usually prescribe glucocorticoids like prednisolone or prednisone. So IV form is prednisone, and the oral gross is prednisolone. And NSAIDs, they might be helpful sometimes, but for the long-term management of the disease, we give disease-modifying anti-rheumatic drugs such as methotrexate, sulfasalazine, TNF-alpha inhibitors such as adalimumab and infliximab. And we send patients to our colleagues, physiotherapists, to have their physiotherapy sessions to manage their symptoms, manage their pain and the stiffness. And in the last case scenario, we go with the surgical option. So I would like to ask my friend and colleague, Dr. Shayan, to explain the physiotherapy section of RA
Yeah, thank you very much for the comprehensive introduction. But I have a question regarding the medications, like the intraarticular infusions or other medications that you mentioned. Do they have side effects such as osteoporosis or other side effects or anything else?
Yes, so any medication have benefits and also side effects for the patient. So these medication which I talked about, I mean, uh, of course, the short-term medications such as NSAID, like ibuprofen, and also the corticosteroid, they have many adverse effects. Like in case of corticosteroids, if we give the corticosteroid, it might decrease the level of the immunity of the patients, so they might get uh, different kind of infections easily. So that's one. But I mean, that is the IV uh, treatment. But in case of long term, of course, these DMARD have many adverse effects, such as pancytopenia, which is the bone marrow suppression. So because of the effect that this drug, like methotrexate, having on the body, it decreases the bone marrow. So these patients don't have enough uh, antibodies.
Right.
And
So
yeah, and
taking,
also I
yeah,
also wanted to mention that these medications are harmful for the patients which are pregnant. So pregnant women, so it has a teratogenicity effect on these patients, those who are pregnant, something like methotrexate.
right,
Yeah.
right. Okay. Now let's focus on the physiotherapy aspect. But let's clarify the difference between RA and OA. So these days, Doctor Google is a problem actually. So people just Google their
Exactly.
symptoms and they catastrophize. They may actually they think they have rheumatoid arthritis, but it might be a simple joint pain or after like some sort of stiffness or soreness in their muscles. So to distinguish the difference between RA and OA, so in RA, as you said, they have morning stiffness, for example, in their neck, in their hands, or in the foot, but it has to be more than 1 hour. And they also have night pain. It's a very important key factor to diagnose the RA. And loading does not decrease the pain in RA. And also their symptoms are bilateral or symptoms, which means that multiple joints get affected in rheumatoid arthritis. And the starting age is after 25, usually between 25 to 50. But OA, on the other hand, their stiffness lasts maximum 30 minutes, not 1 hour, and resting decreases the pain. That's the main difference between RM and OA. And specific joints usually get affected. It's unilateral. Usually one knee or one hip, one side of the hip get affected. And they do not have night pain, and the starting age is in the elderly above 40 years. So Dr. Rodin talked about the laboratory examination, laboratory test, and medical examination of rheumatoid arthritis. Now we do some clinical examinations. So the abbreviation for the examination is SOAP. The S stands for subjective examination. We check their family anamnesis if they had cases in their families, cases of rheumatoid arthritis, if they have previous fractures, and if their subchondral bone is too soft or too hard, is a risk factor for developing rheumatoid arthritis. Also, the laboratory examination, as you mentioned, and we have to examine their type of the pain, where the pain is, when the pain arise, and how is the pain, like what's type of pain, what's the origin, or the if it's a burning pain, if it's a shooting pain, or it's a dull pain. What kind of medications they take, and we also check their active daily living, if they have a sedentary lifestyle or active lifestyle. The O stands for objective assessment. It's we inspect, we look for asymmetries, we look for deformities, and we look for their postures. The deformities that you talked about, like the piano key deformity, the boutonniere, the swan neck, the Z deformity in the tongue, and also in the foot, the flat foot, the hallux valgus, and also they're very common in rheumatoid arthritis. Next, we check the range of motion, namely the active range of motion and passive range of motion. They are significantly lowering rheumatoid arthritis, and they over time they develop contractures. And the type of end fields are bony, spastic, soft, capsular, and empty. And empty. And last but not least is the palpation. We usually palpate their joints like PIP, DIP, their wrist and their ankle and the foot. So some areas might be hypo or hypersensitive. In rheumatoid arthritis, they have a higher temperature, they have general malaise, they have fever, they have edema or swelling, and bony abnormalities such as spurs in their joints. We use some questionnaires to check the progression of rheumatoid arthritis. The very commonly used are HAQ or Health Assessment Questionnaire, EULAR 66 and 68, which investigates the joints in rheumatoid arthritis. And the very, very commonly used is DOS 28. DOS 28 explores areas and looks for tenderness, swelling, ESR and CRP, and visual analog scale or the pain. And with a formula, it gives a number or a value. If the number is above 5.5, 5.1, it shows that the patient has a high disease activity. If it's between 3.2 to 5.1, it's a moderate rheumatoid arthritis, and below 3.2 is a low disease activity.
Perfect. Thank you so much, Dr. Shayan.
Actually, there's one more slide.
Yeah. Okay.
Yeah. For the physiotherapy management, in the acute stage, unfortunately, we do not have that much authority. We cannot do that much techniques. We have so many contraindications because the patient has fever, has swelling, and their joint is under destruction. So we cannot use the TECAR shock wave therapy. We cannot stretch or give resistance training, and we cannot do manipulations. However, we can do some techniques to decrease the pain, such as TENS or ultrasound, and we can give some medications. We can decrease the swelling with specific positionings with using elastic bandages. And in the subacute or chronic stage, we have to prevent contractures, like in the elbow flexion contracture or in the knee contractures are very common. So we have to prevent them by using braces, splints. We can use PNF techniques and hold relax technique, contract relax, and manual therapy, but manipulations are not allowed. We can also do some progressive aerobic training and strengthening exercises to prevent the deformities and to prevent the cardiac compensation or decrease to improve the lung function in RA patients. That was it.
Yeah, thank you, Dr. Shayan. And I have a question about the TENS.
Yeah.
So how does it work for RA patients?
So yeah, TENS is actually, yeah, sure. So TENS is an electrotherapy device. It works with the gating theory. So just imagine you have a pain in your joint. When you rub or when you press your joint, that pain decreases because we have different types of nervous fibers. We have C fibers and alpha fibers, and alpha fibers are myelinated, but C fibers are not. So we are somehow tricking, or we are by giving the electrotherapy inputs, we can temporarily decrease the pain. But TENS works for 1 hour or 2 hours. But after that time, the pain comes back. So it's a way to temporarily decrease the pain, actually.
Oh, okay. Nice.
Yeah. So do you have anything to add or to wrap up this session, Dr. Radin?
I think that was it, Dr. Shayan, and I hope our viewers enjoyed this podcast. I don't know, podcast or video on YouTube, but hopefully we're gonna make much more better contents, data about clinical fields, medical aspects, and also physiotherapy fields soon. And we are going to improve as much as we can to create quality content for our viewers.
Yeah, indeed. I think we are the first channel that we have an elaboration of the medical doctor and physiotherapist. I hope we can share and increase the knowledge by way of podcasts.
I hope. I hope
So
soon.
yeah, I appreciate your time, Dr. Radin. I hope
As same for
yeah.
you, Dr. Shayan. Thank you so much. And we talk soon with the next topic again.
Yeah, sure. Thank you.
Okay. Thank
See you
you.
later.
Bye. See
Bye.
you.